Good evening and welcome to the University of Chicago, Francis and Rose Ewan campus in Hong Kong for our second global conversation live online event, 100-Year Lives in Asia with Professor Kate Cagney. My name is Mark Barnico and I'm the Executive Director of the University of Chicago, Francis and Rose Ewan campus in Hong Kong. The Ewan campus in Hong Kong is the premier location in Asia, which represents the University of Chicago's values of free and open discourse, rigorous debate, and exchange of ideas. The 100-Year Lives in Asia series is one of the new programs developed under the Ewan Lecture Series banner. Tonight, we are again delighted to have a very special Ewan scholar, Professor Kate Cagney from the University of Chicago's Sociology Department, to host the second of several episodes of our program, 100-Year Lives in Asia. Tonight's conversation topic is health and life expectancy. The 100-Year Lives in Asia program will discuss more than aging and the elderly. The program was created for us to rethink the arc of a single human life. No longer can we view education, career, retirement, health, financial security, family structures, and government policy the same in a world where people are living longer and more prosperous lives. We seek to learn lessons from other countries' approaches to aging by analyzing demographically older countries to learn how countries with younger populations can learn from mistakes and policies done right. We also try to get the underlying differences between Western and Asian societies, cultures, and family structures to see what we can learn from one another. Several episodes of the new series are focused on our new reality with COVID-19 and will continue to be broadcast every 2 weeks. Our third episode on May 28th is titled Social Distancing, a Historical Perspective. Please plan to join us for our next online event. Now I would like to get to the program and introduce the chair of 100-Year Lives in Asia, Professor Kate Cagney. Professor Cagney is professor in the Department of Sociology at the University of Chicago and the Director of Population Research, NORC, and the University of Chicago. Welcome, Kate, and thanks for joining us again. The floor is all yours.
Thank you, Mark, and thanks to all our listeners for joining our conversation today. We might say that life expectancy is shaped by the personal, the social, and political, by individual health status and health behaviors, and by the social and physical environment in which the individual is embedded. We may have a sense of general trends in life expectancy, but we really want to ask what drives these trends and how they might vary by important population subgroups or by significant events or crises. So we've brought in two leading scholars to help us think about the complexities of life expectancy and to help us think through all the different determinants that might come into play. First, let me introduce Dr. Angelique Chan. Dr. Chan holds joint appointments as Associate Professor in the Signature Program in Health Services and Systems Research at the Duke-NUS University of Singapore Medical School and in the Department of Sociology. She's also the inaugural Executive Director of the Center for Aging Research and Education. Trained at UCLA with a postdoc at the University of Michigan, Dr. Chan's current research examines disability transitions, mortality, and the effects of social support on health, caregiver burden, and use of long-term care services. She's published widely on aging issues and is co-author of the book, Aging in Singapore, Service Needs in the State, and co-editor of the also an edited volume on ultra-low fertility in Pacific Asia, Trends, Causes, and Policy Issues. Her international body of research includes working with collaborators from Japan and the US on caregiving, work and retirement, and disability. Next, we have joining us Dr. Mark Hayward. He's Professor of Sociology, Centennial Commission Professor in the Liberal Arts, a Faculty Research Associate of the Population Research Center, and Director of the Population Health Initiative at the University of Texas at Austin. Hayward was President of the Southern Demographic Association, has served on the board of the Population Association of America, and was chair of the Inter-University Consortium for Political and Social Research Council. He's a member of the Committee on Population, the National Academy of Sciences, and the Board of Scientific Counselors at the National Center for Health Statistics. Trained at Indiana University, Hayward's research addresses how life course exposures and events influence the morbidity and mortality experiences of the adult population, and that's, of course, what he'll draw on today. Most recently, he's been investigating fundamental inequalities in adult mortality in the U.S., arising from educational experience, differences in these associations by important demographic subgroups like race and gender, and trends in inequality and mortality. Currently, he's part of a national scientific team examining the role of federal and state policies shaping the growing inequality in life chances in the U.S. adult population. Mark, why don't you start us off and tell us, or indeed show us, I know you have some graphics today, a bit about life expectancy across context and help us start the conversation. Thank you.
Thank you so much, Kate. I'd like to thank Kate and the organizers for allowing me to participate in this conversation. I think we'll have a lot of fun, and by the way, you can ask me anything, not just what I'm going to present today. What I'm going to focus on are some lessons learned, I think, from the trends in U.S. life expectancy and how we think about these trends and their implications for inequality and life expectancy overall. I am going to touch on the COVID-19 pandemic and how it will likely play out in the United States in terms of contributing to our growing inequality in life expectancy. And of course, we expect a continued decline in our life expectancy, which has been going on for the past few years. But we paid close attention to two questions. Who are the winners and losers likely to be? And what are the potential lessons that the US has gone through for other countries? To give us a sense of the international trends in slide 1, here's a graph of the mortality of the United States since 1980 up through 2018. The trends are for select high-income countries and administrative areas, and I've included Hong Kong and South Korea, and then the United States. As is evident, since 1980, the US life expectancy has fallen behind other countries and actually declined in recent years. Hong Kong has the highest life expectancy in the figure, and has been consistently near the top of the distribution since 1980, a very impressive record. And then South Korea is a very interesting case because they skyrocketed over this period, and its life expectancy is squarely in this elite mortality group. Today, I'm going to suggest that the pattern for the US, this kind of low rise, plateauing, and decline, is tied to very long-term changes in public, but not necessarily health policies, and the growing role of US states in administering social welfare programs. Indeed, in the context of fighting COVID pandemic in the United States, the lack of a centralized federal response to the pandemic and states having become the pandemic battlegrounds are likely to be major factors leading to an enormous number of deaths in the US in the months to come. When our team began to probe what was under the hood what was in figure 1, what was under the hood of this long-term trend in US life expectancy, we first began to examine educational inequality in life expectancy, considering the question of how inequality may be tethering life expectancy. Here we in slide 2. Slide 2 shows the life expectancy changes by education group since 1990. In each panel of slide 2, the life expectancy for people with a high school degree or less are compared to people with some college and a college degree or more. Especially evident for the graphs on the left for white Americans, life expectancy not only stalled decades ago, but more recently, life expectancy has been declining. In fact, since 2010, all education groups in the United States for whites except for the college educated, have lost life expectancy. Much of this has reflected the opioid epidemic that is rapidly widening what was already a large gap. And now we have the pandemic that we're dealing with, which is likely to exacerbate what we're seeing in slide 2. While we were observing growing educational differences in life expectancy, reflecting the long arm of educational investments for future life chances, we began to see also at the same time period, a growing geographic inequality in life expectancy across US states in slide 3. Through a series of studies, we have learned that the mortality destinies of states like Oklahoma and Connecticut, highlighted on the slide, which used to be very similar in their mortality regimes, diverged largely because of an array of public and health policies that were rooted in what we call the federal devolution of power, which is the federal government turning over to the states the responsibilities for an array of policies affecting healthcare, environmental exposures, anti-poverty programs, and tobacco control. As is evident in the studies that we've conducted, growing responsibility at the state level often leads to the erosion of the social safety net and rising mortality in many states. The growing politicization of state governments has also led to deinvestments, literally deinvestments in some states' populations, along a number of fronts that has contributed to this geographic divide. So what does this all have to do with the figure showing the widening differences I had shown above in terms of life expectancy? Slide 4 provides an example of one policy. In panel A, I show the prevalence of tobacco smokers for 5 states, which are at the top, which had the largest increases in cigarette taxes from the early 1990s until recently. The top 5 lines show that the prevalence of less educated persons declined and converged as the excise taxes increased. Note that no real changes occurred among well-educated persons who have a very low rate of smoking. In panel B, 5 states with the smallest increases in excise taxes are shown. And while there is a marginal downward movement among less educated persons, rates stay pretty much higher than those on the left, and they don't converge. Also, it doesn't matter where well-educated persons live, because those policies don't influence their behavior. So I think we have a few lessons learned from the kinds of things that I've shown you. Policies at the state level are driving the educational inequality. We are seeing inequalities that in education, educational differences in mortality are driving the poor performance of the US internationally. So policies and institutional factors have become, in our thinking, fundamentally important in understanding trends in inequality and mortality, and by extrapolation, international differences that we're observing. I'm also happy to talk about the implications for COVID-19 mortality, where essentially every state has been left to deal with the problem on its own. Thank you.
Thank you, Mark. You've really teed up a number of great points for conversation for later in our hour. I'd like to hand things now to Angelique Chan, and she'll tell us a little bit about life expectancy, also in the context of Singapore. Thank you, Angelique.
Thank you very much, Kathleen. I'm going to talk to you a little bit today about population aging in Singapore and the region in Asia, and some of the policy thinking around it, some of the findings that we have in terms of people living longer but in more disability, more years spent in disability. So if you look at the first graph, you'll see that this is a figure of the population aged 65 and above. And on the x-axis, you'll see the years, 1990, 2000, 2020, where we are now, all the way to 2050. And on the y-axis, you'll see the percentage of the population above the age of 65. Now, Japan is the red line, and they'll be always the oldest population in the world. By 2050, they'll have slightly under 40% of their population above the age of 65. But what you'll notice is the exponential growth in the next 2 lines, the blue and yellow lines. The blue line is Singapore, and the yellow line is South Korea. So Singapore is aging extremely rapidly, but by 2050, we're actually going to be outpaced by South Korea. One of the things that people don't often think about when they think about population aging, and this will relate later to caregiving, is that the population above the age of 80 is growing exceptionally quickly. In fact, it's the fastest growing proportion of the population worldwide so far. So if you look at the numbers for Japan, again in the top red line, 60% of the population will be above the age of 80 in 2050. Singapore and South Korea fall very closely behind. And this has a lot of implications for the onset of disability and the onset of dementia. All of this population in aging in Asia is occurring in the context of, very reduced mortality at younger ages, reduced fertility. In some cases in Hong Kong, South Korea, Taiwan, and Singapore, fertility is around 1.2. In Hong Kong, it's about 0.9 on average, the number of children an average woman will have. We are facing increasing rates of non-marriage, increasing divorce rates, and a change in living arrangements from the traditional co-resident household living arrangement to 1 and 2 person household. In addition, we're seeing a lot of rural to urban migration, and in the case of Singapore, migration out of the country, which has implications for healthcare. Thus, healthy life expectancy and caregiving are major areas of concern for the Singapore government and for governments in Asia in general. And in terms of results that we found so far, people are living longer, but with more years disabled. And I want to show you an example of how different cohorts are living their years of life out differently in terms of proportion disabled. We did some estimations. This is from David Macha's lab at Duke-NUS Medical School in Health Services and Systems Research, where we projected the number of young old with disability. Now, if you just look at the lines, the black line is what the Ministry of Health had projected out from 2000 to 2070. When we took into account education, which is the red dotted line, we found that accounting for education would severely diminish, significantly diminish the projected number of 60 to 79-year-olds with disability in Singapore. So that's a good thing. However, when we accounted for education, we found that the estimates by the ministry, which are in the black solid line, severely underestimated our estimates when we took into account education. What this means is that people are getting more and more educated in Singapore, and they're living for longer, but with more years with disability. So moving forward, policies and programs need to be very flexible to account for changing cohort characteristics. And this is something that we're very cognizant of in the Singapore context. In addition, Asian cultural contexts need very specific solutions to deal with the promotion of healthy aging and to deal with the issues that I say in my next bullet point, which include productive longevity, intergenerational relationships, and the built environment to promote successful aging. So I'm just going to leave it there sort of as an opening so that it can be sort of question generating. And I'm happy to take any questions about this or any other questions that you might have in the context of this webinar. Thank you.
Thank you, Angelique. And Mark, I'm wondering if you'd like to comment on both Angelique's findings and broadly your own on the role of education. I'm struck by the emphasis in both of your presentations and want to think more about the mechanism. What is it about education that delivers either longer life expectancy or better health?
Yeah, it actually probably depends on what outcome you're looking at, to be honest.
Yes.
In terms of the disability outcome, we're likely to see lifestyle changes, exposures, and of course the world has changed around us, and so that those of us that have advanced education are no longer put in harm's way. Mm-hmm. So, there is that issue. At the same time, though, that there's those of us with good education, if you look at the trends in disability, at least in the United States, our prevalence of disability has been going down drastically. If you look at the trends for people with less education, those trends are pretty flat. And in fact, they actually mirror the mortality trends, which is that disability is getting worse among the less educated population. So education here is really defining the opportunities for a healthy life in a variety of ways, good jobs, good relationships, healthy habits, just any number of things that can operate. There's another factor also, which is it puts aside well-educated people simply don't have the stress and dealing with the daily stressors of that less educated people do. So there's actually probably a direct physiological response as well. And if you want to talk about dementia, education is very strongly related to a concept we call cognitive reserve, which is brain development. So I'll stop there.
Angelique, what are your thoughts?
I think education has opened up a whole new world, and just in particular for Singaporeans, since that's what I see. A better diet, a better way of approaching life, but more resources. And it means that our baby boomer generation is significantly different from our pioneer generation. Our pioneer generation, the government has essentially said healthcare is free. But for our baby boomer generation, there is a sense that we would try to get them at an earlier stage in the life course and intervene in order to manage chronic diseases so that they're not such a burden and lead to disability in later life.
The other thing I was really curious about, and I think in part, I'm drawing now in the US context and thinking about our response to COVID-19 and the importance of the states in a way, at least in my lifetime, I haven't seen emerge. And so, that leads me to think about issues related to area. Angelique mentioned the built environments, but wondered if Mark, you wanted to start out and say a bit more about, your broad range of findings related to these important differences by state.
Yeah, I think it really surprised us when, I'm a classic demographer. I tend to look at things like education as being an individual resource. But, Angelique made a really important point, which is that in today's world, it's ripe for people that are well educated to take advantage and really flourish. So we've had this situation where you can flourish under the right conditions. It's like if you didn't have the kinds of opportunities and information-rich environments that we live in, it wouldn't matter that much that you were well educated. And in fact, if you looked in the past, in the 1990s, our educational differences in mortality weren't nearly as large as they are now. So this kind of changing environment, no matter whether you live in the US or whether you live somewhere else, that really matters. I think what we've come down to in thinking about the lessons we've learned from the US states, I think play out internationally, which is when you invest in your populations in a serious way, when you improve their education, when you provide a social safety net, when you think about how you develop a human life from childhood into adulthood into old age, you really do improve the population in a significant way. And when you don't invest in that, or when you invest sporadically or unevenly, or even de-invest in the case of some US states, I'd say, you're going to see the consequences of that. And that's usually growing inequality. And in the US, that growing inequality has really drugged down our life expectancy levels. Now, there's the contrast. I put Hong Kong in there for a reason, right? Just showing that clearly something is going on in Hong Kong where they're investing in the population as a whole. Singapore is the same way. If you look at the trend line I showed for Republic of Korea, something major happened in terms of improving the lives of all Koreans, that made that life expectancy simply skyrocketed so that they're solidly in the middle of the high income countries in terms of life expectancy. So I think those trends are really informative about how governments and policies contribute to the well-being of their populations.
And Angelique, how would you reflect on Mark's comments? And also, how do we think about the structure of Singapore? Are there sort of, if you will, kind of regional or state level differences, and how might they inform some of the issues related to life expectancy?
Well, actually, I mean, Singapore is a very small country, so we don't have a lot of geographical differences in terms of inequality. So we are rather homogeneous in that way. But I think policies in Singapore have taken into account um, growth of individuals from childhood all the way through adulthood. And one of the interesting things that they're doing now for older persons to increase healthy longevity is to put more emphasis on lifelong learning and productivity and volunteerism. And so you can see that there's this emphasis on development of the child, this emphasis on development of the adult through education at midlife, and then now there's this new emphasis on older people and retraining them and having them learn, older being after the age of 50 in our context, and retraining them so that they can live for as long as possible being cognitively and physically active. So I think policies are extremely important, and that if we can get the right ones in place, we can then have what you could call "quote unquote" successful aging.
Angie, can I just want to ask you a question. Do you have data on dementia trends for Singapore?
We don't have trend. We have trend data, yes, and
Okay.
it's pretty consistent. 10 to 12% of the population above the age of 60 has some form of cognitive impairment.
Okay. But
Yeah.
I would expect that in the future it will go down. The prevalence will go down. The numbers will go up because you'll have more older people.
Right.
Yeah.
Right. So we're hoping that the prevalence will go down. Yeah.
Yeah. We've actually seen in the US, the reason I ask this is some work that we've done recently, and it's still in pre-publication form, is that our educational attainment, it changed so dramatically for our older cohorts that are alive today that it literally, if you adjust for education, our prevalence rates for dementia go down. So, or they've just flattened, right? It's just amazing when you think about that. So, I think education matters in these kind of unsuspecting ways. And the situation you described for Singapore is pretty amazing in terms of the likely payoffs of the investments that your country is, doing for the older person, for people in general. They'll pay off a lot in the future.
Yeah, we hope so.
Yeah.
Yeah.
Great. So I think this is the right moment to open our conversation to those who are listening to our exchange now. And so, Angelique, I wonder if you would start us off and comment broadly on the advancement of technology, such as better diagnoses, rehabilitation on life expectancy. I know that palliative care is really central in the Singapore context. And so I also wondered if you would comment on that. It seems to me they're sort of at a juxtaposition in a way. You're thinking about this advanced technology, but then also making choices about potentially withdrawing from some of that kind of engagement. So just wondered if you wanted to speak generally to that point.
I mean, palliative care has been a sensitive issue in Singapore. I mean, people tend to think palliative care equals euthanasia. And in 2008, we actually helped write a report for the National Palliative Care Strategy over at Duke-NUS Medical School. And the feeling that the policy right now is that people should be allowed to pass away at home. That would be the first, priority. And although we have tried to improve our hospice care services, there is a feeling in the research work done so far that individuals would prefer to die at home if possible. So all resources now are trying to go towards allowing that to happen. Educating families, educating nurses, educating doctors about the reality that sometimes people just do not want aggressive treatment and would rather pass away at home. On the flip side, yes, there is this emphasis on technology, and I think this emphasis on technology is happening at the younger ages. The use of apps, the use in 20s, 30s, middle age, huge emphasis on preventive health. I think we were talking with Mark in earlier conversations prior to this webinar that preventive health is really where the action is right now, and where technology can really come in and assist people in carrying out behaviors that are good for their health. So technology has a big role to play. It has a huge role in rehabilitation. Stroke rehabilitation and falls rehabilitation are the main areas that we've been looking at in Singapore. The only thing, and that's why I say culture plays into it, is that we find compared to a US-based population, the want to rehabilitate is lower among our Asian population compared to Americans. There's this thought that I'm old already in Asia, I should be the one being served, I need to relax now. And the fact that we have foreign domestic workers doesn't help. So older people are less likely to engage in rehabilitative services, and that's something that we're fighting against right now, to give them back their autonomy and their independence.
Could you reflect on that, both sort of how we think about technology in the US context, but also this idea that Angelique shares on of how one sees the space one ages in and whether or not we should intervene?
Yeah, I think I agree with Angie that we see a lot of the introductions of technology, especially in terms of disease management. So I think in terms of self-management and self-care, technology has become fundamentally important in the United States. The other part, though, is I don't think that technology has become a kind of substitute that for human care. So I'm pretty sure that's also not the case in Singapore. It's really, there's no substitution. It's a matter of enhancement. But there are countries in where they actually give prizes. So Japan gives a prize for the development of new technology and robotics in terms of helping out its aging population. And so I think that there's a nice combination and complementarity between the use of technology, and it really helps in a kind of complement the kind of self-care. And families, of course, everywhere in Asia and in the United States, there's just simply fewer of us to care for our elder parents. So at some point, you're going to use a combination of resources, whatever they might be. So, I think in some sense, the demand will drive that. In the US, we tend to have cheaper labor. We have we used to have immigration laws that allowed a kind of freer flow of population groups across the borders. Now we don't, and it's hard to see how things are going to change in the future. So we've often had a tradition of substituting using cheap labor for the care of our elderly. We're going to face something completely different in the not too distant future, I suspect.
I'm also, of course, thinking about the role of technology more recently in terms of social engagement and checking on one another. It's clearly been central in terms of the use of families, but also in the context of things like telemedicine, right? Where one can check in with one's physician and make a decision about whether to pursue care. And wondering if you would like to comment on that, how you think, it's unfolded.
Like in the last week, let's see, I had 2 vet visits for my cats. I had, my wife had a telemedicine appointment yesterday for asthma. So, allergies. So we're actively using telemedicine. In fact, I think the pandemic may play a role in a kind of more rapid diffusion and comfort with using the technology that we're using now. I mean, I think we think about how many look at the Zoom webinar that we're having now that we would use to fly around the world, right?
Right.
And now we've gotten very comfortable participating globally, kind of in Zoom meetings, and we've learned how effective they are. So, I mean, it's true that we might not want to sit in our chair 12 hours a day participating in Zoom meetings, but nonetheless, we've gotten increasingly comfortable with this kind of technology. So it's helped. And I think about this, it's keeping us safe.
Well, again, difference in generations. So for the current generation of older people in Singapore above 65, 70% of them have no real formal education or nothing past grade school. So introducing technology to them, if they're living alone or with a spouse only, it's a little difficult. But if they have adult children in the household, it's a little easier. We've been having some success in introducing technology for falls rehabilitation, but some success for management of asthma, management of diabetes, those chronic diseases where you need to check in, say how you're doing, do you need a refill on your prescription? Those are okay, but that's as far as we've gotten so far. So I think there's a lot of technology out there that we haven't taken advantage of.
It leads me to a more general comment. The question has come in from a listener, but just thinking more broadly about norms and values and thinking about how we view aging in context. And Angelique, what if you just want to comment about, is there something distinctive about the way we think? I was reminded of this too because of our discussion of sort of intergenerational relationships, and I was imagining, right, younger people teaching, right, a grandparent how to use a WhatsApp or something like that, and thinking about whether that's situated in a particular normative context where that kind of intergenerational engagement is freer, and does that lead to greater likelihood of informal caregiving, for instance?
I think at this point in time, we know that kind of sharing is helpful, and that in families that have 3-generational households, there is a very positive aspect of technology and how older adults learn. Whether or not it will promote caregiving, that is another topic. But technology is by and large embraced by Singaporeans, and I think by Asians more generally. And I think that it will definitely be a way forward for managing healthcare for baby boomers in Asia.
Mark, we have a question that's come in from a listener, and I think it's a sort of a nice way to kind of think about the distinctions between health and life expectancy. And are they the same thing? And how do we think about these as we assess? And it's sort of a philosophical question, I guess. Yeah.
Well, my quick answer is the things that make us sick are not necessarily the things that kill us. Great. So I think it's always important to think about the differences between health and mortality. We often think of them as isomorphic concepts, but they're not. Angie talked a lot about some disability. Some disabilities come from, let's say, cardiovascular origins. They could be diabetes too. But some come from musculoskeletal wear and tear. And they have much less lethal consequences. So the link between disability and mortality, for example, depending on your group and depending on the population in question, they're just not as isomorphic as you would imagine. So it's not like you're necessarily on the trail downward. You might be on the trail in terms of needing assistance and managing your day-to-day activities. But in terms of the mortality consequences, sometimes it's less clear. The other thing is that we've simply changed the ways in which we manage diseases, and they've become much less lethal in terms of, you know, how we've managed things like heart disease and diabetes and stroke, and we're much better at managing those, and in part because of what you mentioned earlier, the uses of technology and also medical innovation. So I think that so there's that health component, right? The other part is if you were to ask an 80-year-old, you know, to list off their kind of specific conditions, and they would say, oh, I have hypertension, and I have, you know, I'm pre-diabetic, and I have a little heart palpitation. And, you know, if you were 60 and you had those, you'd say, oh, I'm unhealthy. But if you're 80,
Right.
you go, I'm feeling pretty good, right? So, you know, I think there is this kind of normative expectation in terms of how, you know, one's health and also how you manage your health. I think that those kinds of management skills are really important. I think that comes with, and I think the people that are better at managing it are people that are well educated, because we're kind of empowered. We have empowered ourselves to deal with these issues. Angie raises a really an important point, though. When you have a situation where you have kind of rapid social change and your generations are very different in terms of their educational, what they have for their education, then the children, the offspring, who are well educated and much better educated than their parents become a real important family resource to kind of help families, help elders navigate the healthcare system, help them manage their conditions. And that's where this is a kind of education is not just a personal resource, it becomes a family resource as well. So.
Exactly. Yeah.
Angelique, do you want to comment a bit on that? And then we have a listener who asks, what are the lessons Asia can learn from U.S. declining life expectancy? So I thought maybe you could draw up Mark's points a little bit, but also, you know, is there something that can be brought to bear from these findings?
Sure. I mean, like Mark said, adult children now represent a very important resource for the current generation of older adults with regards to palliative care. Oftentimes, the doctors at the National Cancer Center, for example, are speaking to the son or daughter about treatment options and not the older person. And this goes into how we train our medical students. But, you know, there are some cultural aspects in Asia where the older person is seen not as competent anymore to make decisions for themselves after the age of 65 or 70, and the adult child is the one that is now given that responsibility. So very important dynamic, and one that we are struggling with right now in terms of who to educate and who to target in terms of getting the best outcomes. And then your second question was on the preventive behaviors, and why life expectancy is, what can we learn from declining life expectancy in the U.S.?
Right. Yes.
Yeah. I think one of the things that, and this is only my opinion, is that has happened in the U.S. is a disconnect between generations. That's one. Between one's purpose and meaning in life over one's life course. And in Asia, we still, for the most part, have this idea that you are brought up by your parents and educated by them, and your job is to get a good job and then look after your parents. And that kind of story that you tell yourself keeps yourself sort of on track. But once you sort of deviate from that story and get maybe migrate, leave home, those messages kind of get lost, and then it's up to the individual to decide how they want to live the rest of their life course out. The other big issue about the opioid crisis, and again, I am not an expert on this, and the way that the US mortality has been heading is, I think, again, policies and inequality. If you can try and fight against growing inequality, which will happen in any semi-capitalist country, if you can try and fight against that, then you'll fight against these negative consequences. So that's my conclusion.
And Mark, I have to draw you in on that in thinking about.
I agree with Angie, especially about the inequality level. I think that at least in the U.S., we have really neglected the people at the bottom rung of the social ladder, and we've been neglecting them for some time, and we're seeing the consequences of that. If you think about that, we have about maybe 20 to 25% of children now experience poverty as children. A huge number of them are raised in homes without two parents. They grow up in that environment. So we have a kind of group of people which are really left out of the kind of economic conversation, and they have less opportunities for good, healthy social relationships, good jobs, quality of life. And so we have this kind of divided set of groups that is not healthy for, I think, ultimately for our society. It's not that you want to actually control all the rich people, is that you want to actually invest in the bottom rung of your population, and you want to make sure that you have a strong social safety net, and that you are really investing in people, in children, as Angie pointed out. Are you thinking about child development and preschool availability and nutrition and all the domains in which you can improve a child's life, and you just essentially set the stage, if you will, for a really healthy and active adulthood if you do those kinds of investments. So I think that's a lesson learned. I think it's a lesson that we can definitely learn from Asia. But I still think that we run the risk, if you're not careful about managing inequality, especially at the low end. You can have much more rigid boundaries. You inhibit social mobility upward. That's a very difficult situation to have, and it's hard. It's a hard one then to resolve in terms of the stagnation of life expectancy and inequalities in health. So, but Angie's right.
It's good to know. A question came in actually for you, asking about the impact of COVID-19 on mortality rates, and you had alluded to this earlier, but I think that of course what we're observing in COVID-19 is completely in sync with your broader descriptions of inequality and how it plays out over the life course.
Yeah, I mean, right now, I think people should remember we're probably in the very earliest stages of the pandemic. Mm-hmm. I hate to disabuse people of that idea that we're about to wipe it out. We're going to be living with this for probably quite some time. In the U.S., we have a very haphazard way of dealing with it, and so some states essentially have been told that they're on their own, and so we have completely different policies in place about how people should be regulating their lives and how we regulate exposures. That people, so self-distancing is a big issue everywhere around the globe. That's a classic way of dealing with pandemics. And now, of course, when you have some states that are opening up restaurants and bars and tattoo parlors and barbershops, this is probably not, you would say this is not a healthy investment. But remember, we're going to be in this pandemic for a long time. Right now, about 40% of our COVID deaths are coming from 4 states, right? So
great point.
We're the state penetration of the cases is uneven. We're likely to see a much broader spread, especially now that we've relaxed certain restrictions in certain states. So, and even within a state, so I will tell you in the state of Texas, it looks like, that we're not increasing very much in terms of our number of cases. But if I took Houston out of the equation, Houston has crested its wave and it's declining in cases, and the rest of the state, which is heavily rural, is increasing in cases. So what we're seeing is this kind of spatial temporal shift, which, will keep many of us that study mortality and business for a long time. But it really is this kind of, and of course, guess who it's hitting the worst? It's hitting people who can't avoid exposure, people who have to go to work, who are the cashiers, who are essential workers, who are, the white collar workers who are staying at home like me, right, or like you. We're quite privileged in the kinds of ways in which we can regulate our exposures. Other people are much less able to regulate that. And so we see our African American community has been decimated by the COVID pandemic, and Latinos are being decimated, and less educated people will be decimated. So it's that group that unevenness that will even exacerbate what I showed in that graph in terms of the changes in life expectancy, where only the college educated improved and everyone else declined. The COVID-19 will certainly exacerbate that trend. It's not so good news.
No. Do you want to add a comment to Mark's last piece and how we're thinking about COVID?
Yeah, I just wanted to add a comment that here in Singapore, we've been on lockdown for 6 weeks now. We're still on lockdown till June 1st. And we've seen a lot of negative reactions from the older population in terms of they're not understanding and they're wanting to be outside. And we've had quite a few incidents where they've basically, been outside and defied wearing masks and social distancing, and it's difficult for them to understand. So some of the negative consequences of social distancing.
So I feel like one of our running themes in this conversation today has, of course, focused on education. And I have a provocative question here from a listener. So the listener asks, it's interesting, if not surprising, that better educated people live longer and healthier lives, even after adjusting for socioeconomic status. But then the question becomes, would simply raising the educational level of your location or state also lead the individuals right within it to live longer, healthier lives? And what are the policy implications? So it seems like a nice moment to turn to the what if and what can we do and how might we think even about interventions.
Angie, you want to go first?
Okay.
Yeah, Angelique, jump in.
Okay. Well, as the graph that I showed earlier, people with more education tend to live longer, that's for sure. But at the moment, we're seeing them not living longer in better health. So, at some point after the age of 75, after 80, we'll see a higher probability of falls and a higher probability of dementia onset. And education can obviously stall that a little bit, but there's still an issue of the body breaking down at some point. So if we do live to 106, I think we can probably expect the last 10 years at least to be ones that we need care for. So education can definitely help and can help people make the right choices about health insurance and healthcare financing. But I don't necessarily think it can help when it comes to actual physical decline after 85.
Mm-hmm.
We're seeing a pretty good compression of disability by education. So, it really is, and it doesn't matter whether we're looking at physical disability or we're looking at cognition or dementia. On every front of the education, the compression is, it's not that people don't have it, they do. And the declines, the pace of decline is pretty much the same for all groups, except that you push out when that decline starts with with higher levels of education. Getting back to this issue of if we suddenly decided if I were czar and I was able to improve the educational levels of people in the population, I'm pretty confident that yes, I would improve the health of the population in general. So one of the things that we've seen in other countries, in Europe is a really good example, but I think Asia is another good example, is that with this kind of improved prevalence of higher education, all of a sudden things matter in ways that are quite different. Even if not everyone gets the very best job, you're usually getting quality jobs and you're usually establishing quality relationships, and you gain control and mastery over your daily life. And I think that is a really important component. The other part about much of this kind of education is that in preschools and in kindergartens and things like that, especially in other countries, they're actually teaching pro-civil kinds of behavior. So how to be a good citizen. So, there are just a range of ways in which education can benefit an individual. It's not just that I'm going to get the best job on the rung of the ladder. It's a way of actually thinking about the world and grappling with problems and solving problems, because it allows people to kind of have the tools to deal with it and make their own decisions and choices. So you notice that I showed those graphs where how people who were well educated didn't smoke. And smoking policies simply don't matter for them because they have the information. They're making their own decisions. They don't really care what the excise taxes are in cigarettes, because they know that cigarettes are bad for them and they do not consume cigarettes, right? So that's a good example of how a well-educated population can make the kinds of decisions. And when you shift the educational distribution upward, you're going to improve the entire lot of life. So I think education is the master variable. So
Angelique, please.
Yeah, Mark, can I ask one question though? Because what we've seen with education and the first cohort that goes through with education is that they take on all the bad habits, and then we have obesity, we have more diabetes, we have more heart disease because of the lifestyle habits, because there's more income, and there seems to be this, you have to get through that and then education has a benefit.
Yeah, I mean, I hear you. I think partly it is a matter of how fast-paced social change is.
Yeah.
So, I think, but earlier in the century, so in the United States, earlier in the 20th century, when, cigarettes became cool, right? It was cool to smoke cigarettes. But it didn't take long once the Surgeon General's report came out in the 1960s for well-educated people just to kind of drop like a rock in terms of their own smoking. And in fact, it wasn't quit lines, and it wasn't, a variety of programs. It was literally, they were making these decisions on their own. Now, when I talk about excise taxes in differences across states, you think about or less educated people in Mississippi, where cigarette taxes are 55 cents a pack, compared to New York, where they're $4.50 a pack, or in Minnesota. And guess who doesn't smoke? Less educated people in Minnesota don't smoke. It's so expensive, it's prohibitive. So they're making these decisions, and policies are being used in a way to shape health behaviors. And I think that's a really important lesson for how policies are working and how they work differently for different education groups. So we don't have, it's not that we have let me tell you who the binge drinkers are. They're usually the college educated kids coming out of, to be honest. I mean, and we do have some issues with cardiovascular disease that are creeping up from the obesity epidemic. That are broader than across education. but we're not seeing them wipe out the educational differences at all right now.
Okay.
So it seems our hour together has come to a close.
Wow.
And it's gone so quickly. We might have to make these an hour and a half. Just really scratch the surface on some very important issues. But I think you've provided some really thoughtful and in-depth responses to the questions from our listeners. And I think we've been able to think carefully about the role of education and the role of inequality and how they might be linked to life expectancy, both individually and in concert. And I'm wondering if you just want to share some parting thoughts with all those who are gathered to listen to the two of you today. Angelique, you want to?
Okay.
To close?
I really enjoyed today's session, and I think that there are a lot of things that we can learn about how to keep people healthy over the life course, and lessons from the United States for sure. And at the same time, we also need to think about what policies would work for our population. So it's always a to and fro between what's happening in the US and the UK and Japan and then Asia, and then to try and figure out what works best in which context. So it was an honor to be able to hear from Mark today, and I look forward to more conversations.
Thank you. Mark?
So I absolutely agree with Angie, and I can draw the parallel in terms of what has been going on in the trends in life expectancies by states in the United States. So there is no one set of bundle of policies that is automatically going to lead you to a long-lived population. What we see is that a variety of combinations of policies will get populations to the same spot, right? So it's really a matter of having an overall portfolio of policies of a variety of types that reinforce each other and lead to a longer life. Some states have different kinds of people. They have different policies. I think it's the same way when you think about what goes on in Japan, what goes on in Sweden. It really is, you find the policies that benefit the people that where you live under the kind of cultural norms and institutions under which, you can take advantage of and leverage those policies. So I think the bottom line is, I think policies and institutional factors are fundamentally important. We have to be flexible in how we think about them.
Yeah.
And one last thing I would say is that we're so focused in terms of our academic lives and our personal lives and the individual characteristics of people. And we think in terms of health, in terms of being influenced by those individual characteristics. We think of education as being, an individual characteristic. I'm showing in our slides that the effects of education are fundamentally shaped by the context in which you live and work and play. So that's my last.
That was a terrific conclusion. Doctors Angelique Chan and Mark Hayward, thank you so much again for the very thoughtful conversation, drawing out, the cross-cultural similarities and differences and really thinking about these fundamental investments, both at the individual and collective levels and how they matter for outcomes like life expectancy. I encourage our listeners to join us in 2 weeks on the 28th, where we'll be discussing the history of social distancing. Again, thank you so much to our speakers, and I hope you enjoy your day and think carefully about health and life expectancy.
Thank you.
Thank you.
Thank you.
Bye-bye.
Bye-bye.